Welcome. For the next 30 minutes, we'll be discussing the evaluation of the postoperative hemodialysis fistula. We'll discuss some of the controversies, certain tips for enhancing the examination, and potential pitfalls to evaluate for. I have no disclosures related to this presentation, and I'd like to thank my co-investigators as listed below. The reason that we do these evaluations is because of the emphasis that has been given to fistula improvement. In a national campaign by the NIH and Medicare, a Fistula First program has been instituted. In this program, there is additional emphasis on the creation of hemodialysis fistulas as opposed to hemodialysis grafts for hemodialysis. The reason that this has been done is there is literature which suggests that once a fistula is usable, fistulas survive longer with fewer complications than grafts, and also fewer interventions are necessary to maintain a patent fistula. However, despite this added emphasis, still only 40% of U.S. patients dialyze with a hemodialysis fistula. So what are some of the reasons that the fistulas will tend to fail? Well, there's increased failure rates in female patients, blacks, the elderly, patients who are obese, which limit access to the vessels, and then also patients with vascular comorbidities. When we're looking at the different types of fistulas, first of all, I think we should go over the different anatomic variations. A breccia-semino fistula is an anastomotic communication between the radial artery and the cephalic vein. There can be an upper arm cephalic vein fistula which communicates between the brachial artery and the cephalic vein. And then you can have an upper arm basilic vein transposition, and I'll go into this in more detail. The first example that is shown is a forearm cephalic vein fistula which takes an end-to-side anastomosis of the cephalic vein at the wrist as shown into the radial artery. This allows for vascular access within the forearm draining vein once it's completed. An upper arm cephalic vein fistula is an end-to-side anastomosis between the cephalic vein or a venous branch, such as the medial cubital vein, into the brachial artery slightly above the antecubital fossa. A basilic vein transposition is a bit larger procedure where that multiple branches from the basilic vein are ligated, and then the basilic vein is freed up and tunneled beneath the skin more laterally. This is because the basilic vein typically is very medial, and this location is difficult for hemodialysis. So what will happen is the basilic vein will be transposed laterally and superficialized, and then an end-to-side anastomosis, much like the other two types, is performed. When we're evaluating these after the surgery, you need to understand some of the different techniques that are used to optimize the evaluation. The patient should be either sitting or slightly reclined and in a comfortable position. Their arm should be laid out on an instrument stand, usually with the palm up. We use a large amount of ultrasound gel almost as a standoff so that we're not putting undue pressure on the draining vein. In the initial overview, we will look at the location of the vessels. We'll evaluate the feeding artery and the draining vein. It makes it much easier to do this study if you have the surgical note so that you understand what vessels were anastomosed to create the fistula. And you'll notice many of my notes about the tips are in yellow, and you'll notice for a long exam such as this, maybe up to 30 minutes, you really should focus on having the patient in a comfortable position. For the post-op ultrasound technique, we begin with grayscale imaging in the transverse and longitudinal planes. We will then follow with color Doppler ultrasound to evaluate for aliasing. In any area of stenosis, there may be turbulent or increased velocity flow, and this will often wrap around into different colors, creating a disorganized or turbulent appearance. Any area that we find of stenosis will then be evaluated with spectral Doppler using peak systolic velocity, end diastolic velocity, and measuring a ratio of the peak velocity to an area of inflow upstream, approximately 2 centimeters from the stenosis. For all of our velocity measurements, you should maintain a Doppler angle of less than 60 degrees to limit the artifact variability. We will routinely evaluate the anastomosis and any areas of concern. For the evaluation, the frequency of the transducer is important. We like to use as high frequency as transducer as we can due to the high spatial resolution in terms of looking for stenosis or for thickening. However, you must realize that high frequency transducers may not allow detection of high flow velocities, and you may get more aliasing. So when we're talking about the evaluation of the post-op fistula, there are several areas which are a bit controversial that we'll discuss. First of all, size is not enough for hemodialysis fistulas. There are many other factors that contribute to whether it's a usable or a failed fistula. There's lack of standardization in some of the thresholds and criteria that are used. Also, most of the evaluation that we do is a gross anatomic evaluation, whereas there are histologic characteristics which may have an effect. And then we'll briefly talk about whether routine screening of fistulas in asymptomatic patients is acceptable. So first of all, discussing whether size is not enough. It's been shown that for fistulas that are created, if you look at the vessels prior to the surgery, there's no difference in size of the vessels when you're comparing the mature to the immature fistulas. This is once you reach the size threshold of 2.5 millimeters in the vein or 2 millimeters in the artery, as has been previously shown. So even though these criteria may be met for the size, 50% of fistulas may fail to mature. This is due to a number of issues such as stenosis, branches of the draining vein, whether or not the artery is able to deliver adequate blood flow to allow the shear forces to dilate up the vein, and then whether or not there are other factors that may prevent the vein from adequately dilating. When we're looking at the postoperative ultrasound criteria for sonographic maturity, minimum vein diameter is one of the criteria. So size is not enough, but it is still important. If the draining vein is greater than 4 millimeters diameter, these patients were adequate for dialysis in 89% of cases. When they were less than 4 millimeters, only 44% were sonographically or clinically mature. We also look at the volume blood flow of the fistulas, and if the volume blood flow is greater than 500 milliliters per minute, fistulas were adequate in 84%, whereas if less than 500, less than half of these were actually clinically adequate. Be sure and look for the reason if you see a minimum blood flow less than 500. So if you're looking and the flow is low, but there's no stenosis, you need to look closer, A, to find a stenosis, or B, to look for something that's limiting the outflow, such as a central venous stenosis. Now, what happens when both the diameter and the blood flow are considered together? If both criteria are positive, then 95% of these will be adequate for dialysis. Whereas if neither criteria are met, so the diameter is less than 4 millimeters and the velocity is less than 400 milliliters per minute, then only 33% were adequate for dialysis. Whereas these criteria were based on a research study, there are differing criteria from the National Kidney Foundation, or the KDOQI guidelines, which basically have a 6 millimeter diameter, 6 millimeter depth, and 600 milliliter per minute thresholds. This is different from our 4 millimeter diameter, 5 millimeter depth, and 500 milliliter per minute thresholds. To our knowledge, these criteria were basically developed on a consensus panel and are not actually shown by research data. If we were to use these criteria to our patient population, nearly 1/3 of our successful fistulas would not have qualified for fistula formation by their guidelines.